So today we're going through medical emergencies, and we'll go through a couple of questions and scenarios. An important thing before we start is that you will be facing emergencies daily, but it's about using what you do know, so your A to E assessment, and even if you don't know what the cause is of a patient's deterioration, you can always do some things that would stabilize and give time for your seniors or help or investigations to come into their own and guide you. So with no more hesitation, let's go to the first question. I'll have about E. So it seems that we've got the answers in. So it seems the majority of you have gone for answer A, which is the correct answer. So let's just go through it. So firstly, actually going back, what we'll say is from this case, it's pretty clear that this patient may have, does have diabetic ketoacidosis with the clear symptoms of abdominal pain, vomiting, high sugars, and ketosis. And when you're looking at these, you always need to be thinking about what the acid base is and is likely to be for these patients. We know that this is a metabolic problem, and therefore we're not expecting respiratory acidosis and alkalosis in the first. In terms of if there is any respiratory and metabolic acidosis, that can actually happen in this instance, but is very rare. It can only occur if there's really severe DKA with Cat's-Miles breathing. But we know that realistically, DKA is one of the classical causes of a raised anion gap. So what is the anion gap? Well, this is a means for you to differentiate the likely cause of a metabolic acidosis. The key thing when you find somebody who is metabolically acidotic is you need to ascertain, is this because they've lost bicarbonate, in which case this is more likely to be renal causes and obviously gastrointestinal causes, or is this because we're adding anions to the actual circulation, whether that be endogenous or exogenous toxins or chemicals or waste products, which are therefore causing an accumulation of acid within the system. And an important thing to note whenever you're doing your anion gap is that albumin is a big thing and a big determinant of the anion gap. And so you need to correct for patients who may have a lower albumin, which can obviously occur in critical illness because albumin controls how much anions are actually in the plasma. And if not, these will be leaked into the space. And you may be fully aware of some of these acronyms that are used. Mud piles is commonly used, but now Goldmark is becoming a lot more used just because it mentions some of the new ones and new causes of raised anion gap, metabolic acidosis, that were previously ignored. Now, in this instance, we're talking about DKA, and DKA is something that you see in type 1 diabetics, but you can have type 2 diabetics who have ketosis as well. And with DKA, it's very important to note that around 6% of DKAs occur in patients with newly presenting type 1 diabetes. And it can be, type 1 diabetes is quite common, about 4% of patients will have it. And there's usually a precipitant. So whilst it can be the initial presentation, usually infection, discontinuation of insulin, which we're seeing quite a lot actually during this corona times, people stop taking insulin for some reason, stroke, MI, these are all causes for why your insulin requirements can go up and why you can precipitate with DKA. And the classic and the most important thing to establish to really cement the diagnosis is that you have to have this triad present. They need to be acidotic, firstly. They need to be metabolic derived with a bicarb less than 15. That would be quite indicative. And they need to have ketones which are present. And we would say ketones over 3 millimoles per litre is the way forward. And really, we should be using serum ketones, not urinary ketones, because they can actually underdetect and are less sensitive. Now, in terms of classical kind of blood tests and what you may find, you will find that the patients will often have high sugars, and we usually expect the sugars in this context to be slightly lower than those you would encounter in patients with HHS, or smaller hypoglycemic state. They can be usually over 35. Here, you would definitely expect them to be at least kind of over 15, over 20. As I said, you would expect to see the increased ketones, and this is quite simple. The reason for the ketosis is because there is not enough insulin, because you have an absolute deficiency, you can't use sugars, you're increasing your fatty acid metabolism through beta oxidation, which as a waste product through the mitochondria produces the 3 different types of ketones that we pick up. And your dipstick and things, which looks at ketones, measure the 2 most common, hydroxybutyrate and acetoacetate. We can then also see changes to sodium. So I've written that the sodium can be increased or decreased. And the reason for that is that if it's decreased, this is because when you have high sugars, you can get what we call a pseudo-hyponatremia. This is where the sodium is actually lower, is actually recorded as low, but it is actually physiologically normal. And we can think of this as, because the glucose is in the bloodstream, glucose, as we know, has an osmolar effect, and this will make water leave the cells and the intracellular space, moving into the vascular space, and that will dilute the sodium present. But they may also have increased sodium if they have absolute water deficiency because of as I said, because of the renal effects of high sugars, where they're now clearing out so much water that they will get high sodium. And then the potassium is usually, can be quite stable or raised. Now, when we are treating these patients, and we know that the major way of treating patients is through insulin, and we're going to go on to that, we have particular targets in mind, metabolic targets. The most important thing, actually, is for you to resolve the ketosis. And the ketosis can lag behind the glucose falling, all right? And that's quite important. So decreasing the ketones by 0.5 millimoles an hour is very important. You want to see that the bicarb increases by around 3, and the glucose decreases by about 3 millimoles per hour. So these patients, when you have them, these are patients that are intensive. You're going to be with them for most of the night. You need to be doing VBGs pretty much hourly for the first couple of hours, and then you can relax it thereafter, especially if you're seeing improvement. Now, as I've said, the management for these patients is using IVI and insulin. So IVI is intravenous infusions of fluid. In severe cases, we can use bicarbonate. Now, the point about this is actually that bicarbonate is very rarely used in the setting of DKA, even if you've got very severe ketoacidosis. And you should only realistically use it if the pH is less than 7, and this is something that ITU would use. The reason for this is because actually the acidosis that is produced during DKA actually improves oxygen delivery. If you remember your oxygen dissociation curves, then you will cause a right shift of the oxygen dissociation curve, meaning that you improve actual oxygen release to the actual fluid, to the actual cells and things. If you give them bicarbonate and can form then an alkalosis, you can get left shift, and therefore actually you can exacerbate the acidosis by now leading to a lack of oxygen to those cells. Now, in terms of, and also IV bicarbonate has been linked with cerebral edema, particularly in children and young adults. Now, IV phosphate is a treatment that we also use. We try to make sure that levels are above 1 millimole. 1.0 millimoles. But generally, what you want to do is ensure that you have good fluid regime. So if you look at the bottom left, you can see that you give fluids initially quite quick, 1 litre over the first hour, and then you gradually go to 2, 4, and 6 hours. And these patients are usually about 6 litres deplete of fluid. So you need to give them quite a lot. Now, obviously, you need to tailor this to their fluid status. So when you're examining these patients, you want to be checking just to see how peripherally shut down they are. So they need to be catheterized. You need to be saying, what's their skin turgor? How dry is their mucous membranes? And remember, if these patients have had an MI as their precipitant and they have heart failure, for instance, we need to be very sensible with our water and fluid resus. Now, in terms of resolution, to say that the DKA is resolved, it's, as I mentioned earlier, the most important thing is looking at the ketones. And if the ketones are less than 0.6, then and the pH is over 7.3, then we can say that that is resolved. All right, and the DKA has now been resolved. Now, you may ask, well, I've given you those criteria of what we'd like to see every hour with the decreasing ketones by 0.5 millimoles per hour. What do I do if that's not happening? Well, what you would normally do is increase the insulin by around 1 unit, and that will be sufficient. So remember to work out how much insulin that you're going to need for a patient. You take their body weight and you times it by 0.1 units per kilo of body weight. So if they were 70 kilos, they would start off on 7 units of a fixed rate insulin. And then, as I said, if they weren't following those metabolic parameters to suggest they're resolving, you would increase the rate. Now, a big question we always get is how do you switch them? So you've resolved the DKA. You need to make sure they have some insulin on board before you switch them. And quite an easy way to convert them from fixed rate to subcut insulin, take their weight, multiply it by half, and that is their 24-hour insulin. So we'll say they're 60 kilos, so that means they need 30 units of insulin in a 24-hour period. And then what you do from that is you would say 50% of that, so 15 units will be the long-acting, and the 15 remaining units will be the short-acting. Divide those 15 units by 3. You want to give those as the peaks during breakfast, lunch, and dinner, so they'd have 5 units at breakfast, lunch, and dinner. And in terms of switching them, you give them the, usually you would give them kind of short-acting insulin, then you would wait 30 minutes, and then you would stop the actual background insulin that you've given. That's kind of a brief look through for DKA. So let's move on to the next. Okay, so a bit of a split of answers. Okay, so most people, it seems, have just under half have gone for IV atropine, and that would be correct. So let's just go through the question. So there's huge risks here when you're reading through this to suggest that this is, this is a cardiogenic collapse. I mean, he's been walking around, he's gone for shopping, and then he was pale and then flushed, regaining consciousness. And then you found these features. So his ECG is slow, 35 beats per minute, and we've got complete dissociation of the P and Q waves. Now that is, obviously, this is complete heart block, but his blood pressure is kind of tittering on the edge. He's, at the moment, relatively, he's probably going to become unstable. So we need to do something quickly. Now, in terms of monitoring the patient and review observations hourly, I mean, joke, but and in terms of the other measures, these will be things that you'll be thinking of, and we'll go through this. But IV atropine would be the first line. So let's just go through this. So in terms of bradycardia, the key thing that you need to do when you see this patient, always do your A to E. I'm much more reassured if I see a patient who has got a slow heartbeat, who, if I'm talking to them, they obviously, their cognition is there, they're talking to me, they're alert, they're breathing spontaneously. I know that there's end-organ perfusion. So these are the good things. Now, the key thing that you want to establish and see is, because of that, that bradycardia, are they having signs of adverse features? Are they shocked? So you would want to, during UC, check quite quickly, what is their refill, what's their JVP, all these kind of features. And you want to see, possible, as I said, end organ would be cognition, but also, urine output, are they still peeing things? Are they getting chest pain with it? Remember, you need the heart as a muscle. And are they now getting features of ischemia as a result of this thing, which may be the cause of the bradyarrhythmia? And are there signs of heart failure? So you would look for peripheral edema and look at that JVP and consider. Now, if there's features of risk here, and this patient does have some because he is moving towards being shocked, and we know that he's coming with syncope, you would want to give atropine. And the reason is, atropine is very short acting. It'll only last for a couple of minutes, and actually over half of the drug you're going to give will end up in the urine. But it blocks muscarinic receptors, and basically blocks all of them, M1 to M5. And particularly M2 receptors are found within the SAAB node. So this will cause decreased parasympathetic to the heart, and therefore you'll get an increase in heartbeat. It will be quite quick. It won't last for very long, a couple of minutes at best. The point is, what you're looking for is there a satisfactory response? And it's about buying you time. Now, you can repeat this measure up to around 3 milligrams, so that's 6 times. And the whole point is, whilst you're given that injection, you want them on a monitor, you would want to put actual pacing pads on them, which some of you have answered, and you would want to be calling for the crash on your help, but it's about planning what to do next. Now, if in the instance you've done that and things aren't helping, it's about where would you go now? So you can give things, and we, once again, these are the things that you would probably see going towards HDU, but certainly you do see sometimes given on the ward, is about using things like isoprenaline, and that's a beta-1 and beta-2 agonist. But this has the particularly bad part of, actually, it doesn't have any alpha activity. So you actually get dilatation of your arterioles, and it can actually decrease your blood pressure further. So you need to be careful. Adrenaline and things. So realistically now, if you're thinking about using these agents, you need to be moving. And transcutaneous pacing. With this chap with a complete heart block and things, you would be thinking of transcutaneous pacing, but in the immediate thing, you're not going to be able to organize that. You need to give something to help, so you will give the atropine that we've described. Now, what is pacing? So what is pacing? Well, pacing is all the idea that you are trying to provide an exogenous electrical supply to stimulate the heart to contract, thereby allowing for an increase in the heartbeat, but also maintain blood pressure and cardiac output. And, it is scary, I won't lie to you. I've only had to do this once before. And the key thing is, it can be quite alerting and painful for patients. So you want to get anesthetics involved, because they're going to need some sedation, some midazolam, just to really get them through this. And what you basically do is you attach the pads, and you will want to capture the beat. So what you know is, you want to basically ensure that when you're delivering the electrical shock for the pads, it's in sync and it's synchronized with the normal electrical kind of rhythm of the heart, of that patient's heartbeat. So as you can see from the ECG strip that's here, you will see the vertical line going up. So that is a pacing actual spike. And then what you're wanting to see immediately thereafter is that there's a QRS. So this is captured. So what we're saying is that you've given the electrical shock, the electrical supply, and that's led to a ventricular contraction. And it's very important that when you're doing this, you feel for the peripheral pulse, because what you want to ensure, that is the way that you can be sure that you've got mechanical capture. So just like you can get PAA arrests, where you have electrical activity but no actual cardiac output, you need to ensure that there's not only electrical sync, but there's mechanical synchronicity as well. So feel for the pulse and make sure it's in time. You can then set the rhythm. So for those patients for those people who have said about transcutaneous pacing, for this patient, you almost certainly would need that. Okay, as a future thing. But for the immediate step, you want to use atropine. And transcutaneous pacing is quite easy to do and can be done actually, but it does take some time. Transvenous pacing is something that you will very rarely see, and this is because it needs central line access, and it's very difficult because you have to basically attach several leads, two of which are going to the right atrium, and then one into the right ventricle, and they can basically become missed, and the risks of actual hemorrhage are just huge. So you won't really see that being done. But the key thing is trying to stabilize the patient, and immediately that would be the atropine. Right, let's move on to the next question. All right. So, got quite a thing there. So it seems that the majority have gone for the right answer, and that would be for vagal maneuvers. So let's kind of think about it here. So we got a 24-year-old lady who's got poor asthma, and she's come in now with a regular narrow complex tachycardia. So that just say a lot. So this would mean straight away, it's not a ventricular tachycardia, it's not broad complex. Straight away, I'm dealing with the supraventricular, and now I need to be thinking about how best to kind of go about that. Now, in terms of the choices here, the one things I would say is we didn't talk about blood pressure and things, so cardioversion here would be a little bit, a little bit early to consider. But I just want to make clear the differences between synchronized and unsynchronized cardioversion. Synchronized cardioversion is a low energy shock. The whole point is that what we're trying to do is deliver the shock in synchronicity with the normal electrical activity of that heart. Because what you want to avoid is having, you might have heard of R on T phenomena, so you don't want to shock when the patient is actually on the T wave, so during ventricular repolarization, because that would risk VF. All right. So what you're trying to do is make sure that you're doing it in the correct way, and you would use that in patients who are hemodynamically unstable, and we'll go on to that. Unsynchronized DC cardioversion is when it doesn't matter because the patient has a rhythm that is not, compatible with life. So this would be VT or VF, so pulseless VT or VF. You would want to then use an unsynchronized cardioversion shock, and this is a high energy shock. So they are the main differences. Synchronized is low energy and is in synchrony with the normal electrical activity, whereas unsynchronized, high energy, and it's just done at any point in a rhythm that's not compatible with life. Let's go on to a little bit about supraventricular tachycardias. Oh, sorry. So, first of all, there are a few types. So when we use the term SVT, all we're saying is that the location of this tachycardia is above the ventricles. So that means it's from the actual AV node and above. And there are three main types. So we have the AV nodal reentrant tachycardia, and this is probably the most common, and this is your kind of prototypical SVT that we talk about. And the idea behind this is that in the right atrium, you will have two main pathways, two electrical pathways that go to the AV node. And in SVT, what you'll get is one of the pathways depolarizes quicker than the other. And because it reaches the AV node first, that means because the other pathway is still not depolarized, it can reconduct up there. So you get this constant circuit, which involves the actual AV node. And remember, the AV node's function is to delay electrical activity go from the atria to ventricles to allow for atrial contraction. In comparison, and not to be confused with AV reentrant tachycardia, this is where you have an accessory pathway. So this is Wolff-Parkinson-White typically, and this is the so-called bundle of Kent that you will get. And this accessory pathway basically is capable of forwards and backwards conduction. And so, it's not always present. That's a key thing. So when you see this, the classical ECGs with this delta wave and this short PR interval and things, you may not always get that. It's intermittent, and that's the point. But it's very careful how you manage Wolff-Parkinson-White, because if you give them AV blockers, you will preferentially use that accessory pathway because it doesn't follow the AV node. It's a direct pathway between the atria and the ventricles, and therefore you have increased risks of severe arrhythmias. And then the last type is a macro reentrant atrial tachycardia. This is basically a circuit within the atrium. So this is your atrial fibrillation and your atrial flutter. These are the ones that we're thinking of, particularly with flutter, which makes them most common because that's usually very tachycardic. Now, in terms of how you assess this patient, it is scary when you see somebody's patient just climb to 150. I had it about 2 weeks ago, and it was in front of my very eyes. And the key thing is you do the same things as before. Clinically, I want to assess their JVP. I want to ensure that they're not going into heart failure as a result. I want to be looking at their blood pressure to make sure that they're still maintaining cardiac output. And then what I want to be seeing as well is, I would listen to the heart sounds. And the only reason for that is whether or not there may be associated now valvular problems that may have occurred during this, which have predisposed. And we should always be thinking about valves can predispose to arrhythmias. But it's very important to also be careful of if there's any kind of effusions or anything around the heart, which can also predispose. Now, what I've written in the bottom diagram is just to show some important things. So risk factors for any tachyarrhythmia is really if you've had heart attack, because that bit of tissue is non-conducting, so impulses can go around it and you can form these. It's lung disease. So her asthma is actually a big issue. And that is just because of the changes now with how the heart contracts and how it remodels in terms of actually pushing blood through the lungs. And actually the most common arrhythmia that you will see with patients, for instance, with COPD and things like that, is a multifocal tachycardia. That will have P waves present, so it's not one of these where you'll often find them buried in the QRS. But yeah, they're the main kind of things. Now, how to manage it? So vagal maneuvers are really good, and I urge you to know how to do them, all right, to do them properly. Vagal maneuvers can cardiovert someone about 5 to 20% of the time. So whilst you're assessing your patient and you're doing all these things, you get the ECG, you want to put them on a monitor, so you always want a 12-lead arrhythmia patients. You will put them on a monitor, and then you may say to them, right, let's do the vagal maneuver. And as I said, that can cardiovert people up to 20% of the time. It depends on the cohort. And you can do then, so this will involve you kind of doing a Valsalva. So get a syringe, tell them to try and blow the plunger out. That's a great one. You can do the modified Valsalva, where you tell them to lay flat, keep the legs elevated, and tell them to strain. And this will once again help. And something which often our cardiac patients are told about is about using the cold water reflex. And spraying the face with cold water. And you do see people actually use that. Now, if the vagal maneuvers have been given and things aren't really helping, then we need to use something else. I forgot to tell about carotid massage. Now, you can do carotid massage, and that is about using and stimulating the baroreceptors of the carotid sinus. So realistically, all you need to do is go to the border of the thyroid, superior border, and go to the angle of the mandible, and then go midway, and that is your carotid body. Okay? And then give that massage. You need to do it quite firm, okay? And you need to do it basically as firm as if you were trying to squeeze a tennis ball, for instance, and for a couple of seconds. And then you should start to see a response. Now, be careful. You don't want to do this bilaterally, and be careful if they're elderly because of the risks of you displacing any atheromatous plaques. So that's important. So if that's failed, then you want to give adenosine. Now, adenosine, remember, adenosine will cause dilatation of the coronaries, but that will actually slow down, and it's an AV node blocker, stopping the conduction of those electrical activity from the atria down to the ventricles. Now, adenosine is, you need to have a good sized cannula. You need something, at least a pink, really. If not, I prefer green. That's what I put in last time, a green. You want it in the ACF, you need a big vein, and you need a big flush. The half-life for this drug is about 30 seconds, so you need to give them a massive flush, get a 20 ml syringe, give them the drug, and you push it straight through. And you need to warn the patient that they will be very seriously, they will feel awful with this. Now, in the question, it says about this patient being severe asthma. She would not be suitable for adenosine because of that. Okay, it will cause bronchoconstriction, and in COPD, you need to be careful as well. Yeah, so COPD you can use it in, but asthma, you would certainly not want to. You would not give it, it would be completely contraindicated. And then basically, if that's not an option, you would want to give IV verapamil, which you can give. It's often in your crash cart as well, so you can give that. Now, after your vagal maneuvers and things, you would have been calling for help. So I would implore you to put a 2222, because if they're going to become unwell and becoming more unstable, then you would be thinking obviously of cardioversion. And as we said before, this would be a synchronized DC cardioversion. And once again, the reasons why you're going to do this are the same as we've said before. Have they got signs of heart failure, signs of ischemia? Are they syncope? So if they're talking to you whilst this is happening, that's quite reassuring. If they're now collapsed into the bed and the heart rate is 170, 180, you want to be getting and doing a synchronized shock. And you can do up to 3 attempts of that. And then basically from that, then you may want to, especially if it's starting to slow down, or if there's delays in getting shocked, you may want to start them on amiodarone. So you will give them 300 milligrams over the first kind of half an hour, and then you give them 900 over the remaining kind of 24 hours. And that way, then, that is a chemical cardioversion. And patients usually respond very well to that. Remember, if you're giving cardioversion and you're shocked, there are risks with that in terms of displacing, for instance, you may displace clots that are in the lungs, so there is a risk of stroke and things. Now, in terms of ongoing management for these patients, if they've had that, then you need to really look at the risk factors to see why they had it. Was this idiopathic? Was it electrolyte disturbances that may have precipitated this illness? As you know, for instance, atrial fibrillation, very common in patients with pneumonias and other, just bad illness and sepsis. So treat the underlying cause, but they may need, especially if they've got accessory pathways, ablation and different things. And for both Parkinson and White, as I've mentioned before, it's about being careful about what drugs you do use in that instance. But that's a bit beyond this, and that's for specialists. So let's move on to the next question. I will be answering all questions at the end. Okay, so this has caused a bit of a difference here. So a lot of people have gone for fluid restriction. The actual correct answer for this would be about giving 3% saline. Now, what we'll do is we're going to go through hyponatremia, and then we'll talk a bit about the management and why you would go for one or the other. So hyponatremia is very commonly seen, okay? And the big things I want to say to you is that hyponatremia, the two things you need to think about, well, three, is what is the level of the hyponatremia, firstly, and how quickly did this occur? So actually, there's only two. They're the main things you need to think. If they've got chronic, if they've got developed hyponatremia over weeks and months, that is very well tolerated, and patients will rarely come with many symptoms. However, in the instance that is acute, they can have very severe symptoms indeed. And we've written here on the kind of the table to the right-hand side about the severity. Now, you will see here less than 125 progressive neurological symptoms, confusion, coma. Realistically, you're going to look at that between kind of 115 and below, okay? Now, what I would say generally, in hospital, I'm not too bothered about sodiums of 125 and above. They very rarely cause symptoms, and if they do, it's non-specific malaise, some nausea, and they will get just a little, sometimes some mild confusion, particularly if they're elderly. But you generally, anything less than 125, that's where we need to be worried and actively doing something. Now, the key thing in terms of hyponatremia is that you need to establish that it's a true hyponatremia. And remember, sodium is the principal component of determining your effective circulating volume. So it's incredibly important. So we can measure the osmolarity, and this is something you can do at the bedside, and it's very easy, and very few people do it for some reason. So it's just 2 times the sodium and the potassium plus the glucose and the urea. Now you can get all this information even from a VBG, because some VBGs can give you urea as well. Otherwise, you can just take this from your UZDs and the bloods, which we have already done. And the point is to establish, is this a true hyponatremia? Now, if it is true, then the serum osmolarity should be lower than normal. And you normally say that 280 is kind of our normal osmolarity. So if it's less than 280 and the sodium's low, this is a true hyponatremia. Sometimes, however, you may get the cases where the sodium comes back as low, but the actual hyponatremia, it doesn't exist. And so the actual, when you work out the osmolarity, it's normal. Now, there are very good reasons for that, and that is that the main ones are increasing in lipids and protein, or in the instance of hypoglycemia. So what we say then is, for kind of the reason why we get that with particularly, for instance, lipids, so this is a classic exam question, is only because of how the laboratory measures it. So if you imagine a test tube full of serum and you spin it down, then if you spin it down and from the 5 mils of blood that you've taken, 4 mils of it is lipid, because they've got so much lipid in their system, then when the machine measures that 1 remaining mil of plasma to look at the sodium, then it will come up as low, because it's not, it thinks it's of the 5 mils. So does that make sense? And they're looking at the sodium content in that 1 mil, which the machine thinks is a representative of the 5 mils, which means that it will be low. Right? It's a fifth of what it should be. That's the basic principle. But that's why it's quite important. And whenever you deal with somebody with low sodium, you need to do their urine osmolarity at the same time. The reason is, too often than not, patients will have already started receiving IV sodium. And if you've got hyponatremia and you start giving them exogenous sodium, they will start to have natriuresis. They will start losing sodium through their urine, and therefore you will change now the osmolarity of the urine, which means that it'll be very difficult to interpret. But the key thing when you're examining these patients, aside from these lab tests, is looking at their fluid status. As I've said, sodium is the principal kind of method by which we maintain our effective circulating volume. So do a good fluid assessment. So that means JVP, peripheral edema, sacral edema, and then looking for skin turgor. So that, when we say skin turgor, it basically means when you pull up the skin, does it stay up or does it go back down? And if you're dehydrated, it won't go back down because your dermis is now there's a lack of water there. Your glycosaminoglycans aren't attached to water. So that's it. And then we look at the fluid status. So if they're hypovolemic, all you need to remember is that this is due to all the failures, okay? Failures of heart failure, renal failure, liver failure. And this is because of that deleterious effect where you will get increased activation of your renin-aldosterone system, And this leads to worsening kind of increase in water reabsorption, and basically, it's a perpetual cycle of worsening heart failure or liver failure. These patients can be difficult. You then can have euvolemic. So euvolemic doesn't mean that they're just normal. It means that there's very little. So what I would say is for euvolemic is that they may have a tiny bit of edema out of keeping to cause this level of sodium drop. Does that make sense? So you might notice, it's very common. All of us get, we'll get swollen ankles. So you might have a little bit of edema on the ankle. But I wouldn't be expecting that to cause such a significant hyponatremia, for instance, 125. I'd expect, if they had genuine heart failure, for them to have edema up to the knees. When euvolemic, we think of several causes, of which hypothyroidism is a very common one, and that's because of how thyroid hormone affects cortisol metabolism, and therefore, remember, cortisol is involved with water reabsorption and things. But classic ones, drugs. Always remember your drugs. So SSRIs are very common means to cause this. Obviously, we have glutamides and things like that can cause issues. But once again, we expect that to move into the hypovolemic. But always look at drugs. And potomania. So this might be new to some of you, but this is beer potomania. And this is the idea that, remember, this is all back to physiology, how you absorb sodium and how you ensure that you concentrate urine. You need to have a medullary concentration gradient. If you're somebody who just drinks beer and you don't eat, and we must remember you need to ingest about 2 millimoles per kilo of sodium each day just to keep your sodium levels normal, then you can't form a medullary concentration gradient, because beer, for all of its great taste, doesn't have any major electrolytes. It doesn't have a lot of sodium. So therefore, because they can't form a medullary concentration gradient, they can't absorb, reabsorb water and reabsorb everything else. And so what do they get? They get this issue where they will become hyponatremic. And then we have hypovolemia, which is probably the most commonly going to see. Now, this is where urine osmolarities are particularly helpful, and we can look at the urine sodium. So, if you are dehydrated, you would expect what? Well, you would expect activation of your renin-aldosterone system. You would expect there to be increased sodium reabsorption, and therefore decreased sodium in the actual urine itself, because we're trying to salvage as much as possible. Now, if you're hypovolemic but the sodium is high in the urine, then this must mean that there's something else dragging you down. So diuretics, for instance. Diuretics are obviously breaking that cycle, leading to sodium being lost. Ketones will once again do that. They will exert an osmotic effect. Or if you have aldosterone deficiency, once again, that would be a cause. If the urine sodium is low, then this means the kidneys are working fine. The kidneys are doing their job. They're trying to reabsorb the sodium as we'd expect. I must be losing the sodium from somewhere else. So vomiting, diarrhea, and pancreatitis would be the kind of most important things. I should go back just to say about SIDH. SIDH works on that principle of you should see like for like in your osmolality. So if the osmolality is low in the plasma, it should be low in the urine. If you don't get that, then SIDH should be considered somebody who's euvolemic. So that is, you've got confirmed hyponatremia with less than 280 milliosmoles per kilo in the serum, but their urine is more concentrated and their urine sodium is over 40, it's high. So this means they're not trying to absorb the sodium, and they're actually making concentrated urine in the context of concentrated. They're trying to make, in the context of concentrated plasma, they're making dilute urine, which doesn't make sense with high sodium. This is SIDH, and this is what requires you then to think about fluid restriction. So we're going to talk about a bit of management. Now, as I said, the cause and duration and symptoms are really important. Now, this woman came in with seizures and her GCS has dropped. This is now in the severe category. I would be expecting, as I said, her levels to be like I would say about 115, less than 120 for sure. Hers was 119. Because she has such severe symptoms, we need to treat that. And so you would, in this instance, give very small volumes of 3% saline. And what you want to do then is measure the sodium a half an hour after, and you're expecting the sodium to basically go up by about 5 to 6 millimoles. And you really want things to do that. Now, you can repeat the measure, but giving hypertonic saline is very, very dangerous. And this is because of the fluid shifts that it can cause. Now, if you think about it, if I've got somebody who's got low sodium in the plasma, if we think about the typical cell, if a cell was placed in low sodium, then what would happen to try and increase the osmolality in the plasma, then water would leave and go into the cell, causing that cell to become edematous. Now, if I give a lot of exogenous sodium in one go, then I will raise the extracellular sodium very quickly, or could do so, and then this will mean that water leaves the cells and goes into the plasma. Why? Because it wants to dilute that sodium. Remember, obviously, water moves from low to high concentration. Sorry, from high to low. So it's trying to dilute that. Now, it's very important that you limit the rise that occurs in sodium in hyponatremia. Now, traditionally, and I still am a big believer in this because there's no evidence for otherwise, if it's acute hyponatremia, so that means it's less than 48 hours, then it doesn't matter how quickly you increase the sodium. And the reason for that is because your osmoreceptors and the cells themselves haven't had enough time to recalibrate. And so you will avoid the massive fluid shifts that we've talked about. However, if it's chronic, that means that the osmoreceptors have changed. They might be used to an osmolality in the plasma of 260. And so if you raise that too quickly, you can predispose to huge shifts in fluid. And obviously, in this context, the big thing we worry about is something we all know about, which is pontine myelinolysis, cerebral pontine myelinolysis, which is actually now called osmotic demyelination syndrome, because we know now that the changes occur not only in the not only in the pons, but throughout the CNS. And this is where you get basically stripping of the myelin sheaths. And actually, when I was an F2, I had to, for a whole weekend, keep on reassessing a patient with hyponatremia who was having their sodiums increased, and sometimes they were jumping quite quickly indeed, for signs of this. And the key things that you're looking for is whether they develop any spastic paraparesis, and particularly because of the pons involvement and things, you will develop dysphagia and dysarthria. So doing a full neurological exam is kind of mandated. And for somebody, if somebody comes to you with a low sodium of about 120, I would implore you to do a full neurological exam, including swallow. Now, in terms of if they're hypovolemic, then yes, if they were dehydrated, you would give saline. How quickly, as I said, you want to try and raise it once again between 10 and 12 millimoles. If they're dehydrated, giving them a 4-6 hour bag is more than sufficient, okay, providing that there's not severe symptoms, and that once again, that we think that, that it's not sufficiently low that we think it's going to go on to form symptoms. So if it was 120, say, I would want to give the sodium a bit quicker, providing they had no ongoing symptoms then, but I would have the contingency of giving the hypertonic saline that we've described. Now, if they're normovolemic, which is what we talked about with the SIDH, then we want to fluid restrict. Typically, you will say to people 1.5 litres, like you've probably learned before. In reality, you usually see people go to 1 litre. And actually, in hospitals, patients very rarely drink. We have to force them, especially if they're elderly. Now, SIDH is obviously is a diagnosis once you've made it, but there's a cause, and that could be secondary to drugs, carbamazepine and things. This could be secondary to pneumonias, cancers, meningitis, different infections. So it's about finding the cause and the likely precipitant for the SIDH. In terms of treating it, if fluid restriction isn't working, then you need to think about using agents. So you can use democlocycline. Democlocycline is used in the textbooks, but basically that blocks ADH action. So you form then a nephrogenic diabetes insipidus. So that is where the kidneys are now insensitive to ADH, and so what you will get is effectively clearing of excess water, and then you will artificially rise your sodium level. Otherwise, what we can do is the Vaptans, and these are quite important as well. These are quite expensive, I should add, and they can give really good results actually, but they can be difficult to get, and that's another way to do it. So Vactans are used, and they block basically the V2 receptor that is present in your collecting duct. If they're hypervolemic, then you want to diurese, and that might sound counterintuitive, but you want to get rid of the excess fluid and the excess water that is obviously diluting the sodium present. So, with your heart failures, a typical regime would give 14 grams BD. Obviously, tailoring that to blood pressure and how they are clinically, because it might be more beneficial in that case if they want a fluidized, for instance, infusion. So that's enough on hyponatremia. Let's move on to the next one. Great. So it seems 82% of you have got the correct answer. So what you want to be doing is IV thrombolysis. So that is correct. So we'll talk a little about PE and just some important things actually, and then we'll talk about what is massive PE as well and the management and outcomes. So PE is incredibly common. Guys, you're going to see this so often, and you're going to write query PE about 1 million times in your life. Remember, pulmonary embolus refers to obstruction of the pulmonary tree. This does not just mean thrombosis, okay? It also means that it could be a fat embolus. And I would implore you to read about fat emboli, particularly if you're doing orthopedics, because that's very common, and that will present very differently with congenital bleeds, rash, and eosinophilia. Obviously, the main causes are thrombosis, and in around half of cases, there is a DVT present. Now, we all know about the risk factors for PE and DVT. I'm not really going to go through that, but knowing how to do the Wells score is really important, and this is a good, thing for you to be aware of. And the table's there, but it's just basically, looking at what the common causes are and what would make you think of DVT. So basically, of PE. Sorry. So is there clear signs of DVT? Have they had one previously? Is there hemoptysis? And typically, when you think about PE for these patients, it's usually because they have, in all fairness, they're more breathless, and you find that they're hypoxic, and they've got non-specific chest pain, or they have an isolated sinus tachycardia, which you can't explain. These are the type of things that you're really doing it for. And remember, you can get low-grade pyrexia as well. It's 37.5 is not uncommon. Now, in terms of investigating, you will always hear about the D-dimer. Please be very careful about doing the D-dimer. The D-dimer was never meant for PE. The D-dimer was established for doing aortic dissections, but the D-dimer is a degradation product of fibrin. So obviously, when we break down fibrin through a plasminogen activation system, you form these products, and that's what we pick up. And we know that it's very, very good because of its negative predictive value. So if it's negative, we can be relatively reassured. There are false positives, and I really want to turn your attention to this. If you've had surgery within about literally 10 days to 4 weeks, you'll have a positive D-dimer. It's meaningless. Don't do it. They've had the operation, and you really think that they've had, if you really think that they have, you would probably proceed to scanning or doing an ABG in the first instance. Don't do it for that. Pregnancy, the D-dimer continually increases during pregnancy. It is not a reliable marker. Do not do it. If they've got cancer, they will most likely have a positive D-dimer. MI, stroke, they will have positive edema. And infections, cellulitis and DVT, you always hear about, well, this, it looks cellulitic. We'll just do a DDOM. Well, it's going to be positive, so I don't really know why you were doing it. I remember when you look at a DVT, it's usually pitting edema enlarged, but it's not usually too red. Cellulitis it is. Now, in terms of other investigations you will do, ABG, this is probably one of the few times an ABG is very important to do, especially in the context that they are hypoxic. And one of the key things here when you do the ABG is understanding about the AA gradient, which you don't get taught really very well in med school, which is alarming because it's really helpful. So the AA gradient is telling you the difference in the partial pressures of oxygen between alveolar, i.e. what I'm breathing in that's going to my lungs, and what is the actual concentration of oxygen in my arteries. So it can tell you what the cause of the patient's hypoxia is. So you can see the equation here of how to work out the alveolar concentration. So we know that what we're breathing is 21% air, so you factor that in. Factor in the PCO2. Why? Because PaCO2 takes more space of an alveoli. So if you're hypercapnic, you will definitely, that will occupy all the space, so you will have hypoxia as a result. And then you divide by 8, which is the respiratory quotient, over 5. Now, the point is, when you work out the AA gradient, it will tell you what could be the possible reason for why you're not getting the oxygen from the alveoli into the artery. So if you work out the gradient, and you can work out a normal gradient, but if it's normal, so they're hypoxic, I can see that. I've measured their gas. The PaO2 was, we'll say, was 7.8 on whatever, on room air. 7.8, 7.6. And then you've worked it out, and it's a normal AA gradient. So something's happening. They're breathing it in, but it's not moving across into the arteries. There's only really 2 reasons for that. So one of them is hyperventilation. So they're not breathing enough, and then the carbon dioxide is building up. The carbon dioxide is much more diffusible across that membrane, and it'll take up much more room in the alveoli. Or it's because my oxygen is not of a sufficient concentration. So imagine if I put someone in an airtight room, then they would, and there was a lack of oxygen there, eventually there would, over time, there would be a lack of oxygen going into the alveoli. However, the same proportion would be going across into the actual arteries, which is why the gradient is normal. So there's nothing blocking the diffusion of actual gas from the alveoli into the artery. So that's why it's a normal gradient. If you have a raised gradient, so I've got the oxygen coming into the alveoli, but nothing is going through, hardly any of it is moving into the arteries, then this must mean that there's one of kind of usually 2-3 things. There is a VQ mismatch, so which PE is probably the most important one to think about. So this is I've got air going to the alveoli, but no blood flow. Or it could suggest that you have cardiac shunts. So remember, Eisenmenger syndrome and things like that, if you have an ASD or VSD, for instance, if you form a right to left shunt, then the blood is going to move and bypass the lungs entirely. So your arterial oxygen will be low because deoxygenated blood from the right side of the body or the right side of the heart is mixing with the left. So it's going to be low, and that's the reason why they're hypoxic. So it can be quite useful. Now, in terms of massive PE, that's what we're kind of showing in the scans above. So massive PE can be shown in that CT. You can see that black substance there. So if you've got bilateral, this is a saddle PE. This is blocking both of the pulmonary arteries, and this is very, very serious. Likewise, on the chest X-ray, you may see this pacification that you can see that looks really well defined. It looks like a wedge, and this is the typical thing that you'll see, a wedge kind of wedge infarct, or also described as a hump, and this is called Hampton's hump, and this is basically pathognomic of PE, but you will see this kind of rarely. Now, a massive PE is that you have systemic hypertension for at least 15 minutes that requires inotropes, you're pulseless, or you have profound bradycardia. So basically, your hemodynamic instability. And that is the real reasons for doing thrombolysis for these patients. It's very important to be aware of that. Now, how does PE cause hypoxia? So we've already mentioned, because, how does PE cause problems of the heart? Well, it's all about, if I have a lack of oxygen, what was going to happen? Well, if I have a blockage, and a thrombus there, I'm going to have a lack of blood flow to a particular area of the lungs, so I can't have a VQ mismatch. The hypoxia will cause vasoconstriction. The vasoconstriction will cause increased pulmonary vascular resistance. And because of that increased pulmonary vascular resistance, this will lead to the right ventricle becoming dilated. And this is all, because think about your cardiac physiology, your Frank-Starling curves. Remember what we said, if you have increasing end diastolic volumes, then you would expect an increased ejection fraction, and you would basically increase your, what's the thing I'm trying to say? Increase your stroke volume. Obviously, on the right side of the heart, it's thin, very thin, the ventricle is. It can only generate pressures literally about 25 milligrams of mercury, hardly anything. So it struggles. And so what you will get is dilatation of that, bulging of the intraventricular septum, or towards the left side, and you may get blood refluxing backwards now, because there's nowhere for it to go. The right side can't pump it, and it will go then into the basically hepatic veins in the IVC. And that's why you can get pulseless, and PEA with PE is something that you can see because of this. So in terms of management and things, the key thing here is we know that you give thrombolysis, and we know kind of how to do that. So thrombolysis, you're using, often than not, you're using things like streptokinase, and this is something that is a consultant-led decision. You'll never have to make that. But if you see somebody who's hemodynamically unstable with their clot, with their PE, and you've got signs of strain. So what I mean by that is signs of the right heart, the right side of the heart is under strain as a result of that PE, which you can see on the CT scan by what I've mentioned, so reflux of blood into the IVC and the hepatic veins, or because there's flattening of that IV septum, because it's now bulging, then you would want to flag this up to your senior, because this patient may need one. And what we say is, going forward, is if they don't need thrombolysis, but they're stable, then you would want to give them, in the first instance, you may give them low molecular weight heparin, if, of course, you're buying time for the scan, you've clinically made the diagnosis, or you can give, actually be given the first instance rivaroxaban now, and we can give that. So these are for patients who are non-massive PE, we can give them that, and there's a treatment schedule for that. Now, in terms of when you're giving the idea between thrombolysis, the reason why it's a consultant-led decision is because you need to be thinking about the risks, and the major risks are bleed. So you want to avoid it in patients who obviously had any recent stroke, or who have an active CNS tumour, because that will bleed. Any major trauma or surgery in the last 3 weeks as well, and any active bleeding, okay? Not if they've had, for instance, if they've had past bleeding, GI bleeding about 3 months ago, you would want to discuss, but that could be an indication to give it. Now, in terms of the treatments, we know that you can use warfarin and low molecular weight heparin to help you bridge, or you can use DOACs. DOACs are non-inferior, okay? So DOACs are the new kind of thing to do. Obviously, for some, for most patients, DOACs are the way forward. You can't, they haven't really been trialed that much in pregnant women, so you'd want to be careful, and you would give them heparins. Likewise, if this is a PE associated with actual malignancy, then in the first instance you would want to give them low molecular weight heparins as well. But if they're patients who've had thrombolysis and you're wondering what to do next, then after you've given them this and you're hoping to restore cardiac output, you would want to give them unfractionated heparin in the first place. And that's simple, because unfractionated heparin has a half-life very, very quick, actually, only a couple of hours, 4 to 6 hours, and therefore you can stop it, and it will leave the system quite quickly. And obviously it's better if they've got any coexistent heart failure. Now, a big question we always get is about pregnancy, and patients will ask about scanning and things. What I would generally say to you about that is, you will be asked this. Chest x-rays I have had pregnant women refuse chest x-rays. They're like, oh, my baby. And what I say is generally, you get the equivalent radiation dose from a chest x-ray every 3 days living on this earth. So I say your baby, 6 months old, it's already been exposed to 60 chest x-rays. So it's fine. Now, in terms of CTPA and VQ scan, CTPA has, fetal exposure is a little bit raised. So they will expect, I think, the overall cancer risk for the mother is increased by about 0.6 to 2.5%. Whereas to the actual fetus, you're looking at, I think it's like 5% over the first couple of years. But realistically, in pregnancy, CTPA is actually inferior. It doesn't give you as good quality images, and it's actually less diagnostic. So VQ scan is always the way forward. And the risks to the baby, whilst they're slightly increased, are still incredibly low. So VQ scan all the way. Now, one thing I would say is that kind of going forward, if you've had thrombolysis, you've had the unfractionated heparin, what are you going to put on next? DOACs. Some people are still quite nervous about giving DOACs because they haven't been shown in massive PE. So most people will go on warfarin, and I've discharged patients on warfarin as a result of that. There aren't major trials, but watch this space. It'll probably change over the next couple of years and things. And if you're an A&E and you think somebody's got PE and you've treated them and they're going to come back the next day, for instance, for to be seen by the medics and things, then you can use the PESI score, so that's the Pulmonary Embolus Severity Index, and that will basically give you what their 30-day mortality is, and that will make you feel a lot more confident about discharging them to come back in the next day. Obviously, once you've given the treatment dose, low molecular weight. Now, in terms of outcomes with these patients, the major kind of issue is that you need to warn the patient that they will have breathlessness. It amazes me how many patients do not think that once the clot or once everything is removed, they're surprised that they'll have any residual symptoms. Think that you get symptoms for months, weeks and months actually after pneumonia. It seems shocking to me that one wouldn't think that you would get the same, if not worse, from a clot. And certainly when you follow up these patients, you can see that the dyspnea will follow them through for up to 6 months and can even go to 3 years, particularly if it's massive PE. A major thing as well is that you can get pulmonary hypertension, so chronic thromboembolic pulmonary hypertension. And this is a big issue as well. So this is now where, because of that blockage, you've got that thrombus, which is including there, you now get changes to the pulmonary vasculature such now that you get increased vascular resistance. And the right side of the heart now is under increasingly more strain and is trying to push through a very rigid set of lungs. And this can be quite difficult to manage. These patients are eligible for vasodilation therapies, but it can be very, very debilitating. So for instance, with our case, with this severe PE, this life-threatening PE, this would be diagnosed. We would, if they were like that and they're too unstable to go to a scanner, you would do the echocardiogram. So you do an ABG, you would do things like that, and then you would do an echocardiogram bedside. In this patient, this is where cardiology comes down straight away. And what you want to see is those signs that I said, that the right ventricle is under strain. You would want to see that the pulmonary artery pressures are very, very raised, and that makes sense. There's a blockage there to the vascular resistance is so high, and the right ventricle is having to push very hard. And what you would want to do is realistically repeat these assessments of the echo if they've recovered about 3 months down the line to check now, is there permanent pulmonary hypertension as a result of this? And then going forward, what you need to do is obviously come up with a plan to see whether they need long-term anticoagulation. So normally we give up to 3 to 6 months, depending on risk factors, and they will be followed up in the thrombosis clinic. So you need to ensure that they've got that follow-up. And what I would say is, before they go, if they're under 50 years old, strongly think about giving doing a thrombophilia screen. And that can be really important. And you might be asked to do that. Okay, let's move on to the next question. Okay, so 80% of you have gone for the correct answer. That is aortic dissection. There are a few clues here. Severe, obviously, sudden onset chest pain, but that could be a few things. The key things here that would make me think about this: he's got weakness in both of his legs. Always think about this. That sounds like a dissection to me, because we have to remember, obviously, the aorta is providing blood supply to the rest of the body, whilst your spinal arteries and things come actually from your vertebral arteries. Major blood vessel is actually from the aorta, so they're getting spinal now infarction, ischemia. But classic here is this new diastolic murmur. All right, if you see somebody and you've got a new diastolic aortic regurg, which is what is suggested here, you think aortic. So what is aortic dissection? This is quite common, and sadly, most patients, a good 20%, depending on how bad it is, a good 20, even more, will die before they reach the hospital. It's much more common in males with risk factors. Hypertension is probably the most important. Have they got an aortic valve disease, which will already put them at risk? And then the obvious ones are things like Marfan's, and certainly as well drugs. Are they on amphetamines and cocaine and things? Because you can get hypertension, weakening of the aorta walls. Now, typical with aortic dissection, different from an MI. An MI, will usually, the pain occurs quite not gradually, but it occurs over minutes, and then it will get at its peak. And that's why you get the typical history of 30 minutes chest pain, for instance. Aortic dissection is like the subarachnoid of the chest. Very pain, and it's maximal at the time of onset. Usually interscapular, how it's described. And what you will kind of see when you kind of assess these patients is that you'll see, they'll be shocked. They may be shocked. They'll be in a tremendous amount of pain. You need to give them usually opioids. And then, for the ECG, you'll probably see sinus tachy, but it can be normal in up to a third. They may also have the typical changes. So they may also have actual infarcts. And that is because, remember, the coronary artery blood supply is from the actual aorta, where the sinuses are. So, if there's a tear there and there's lack of oxygen, you may get reciprocal kind of MI. So that's why it's important to do an ECG. Particularly, your right coronary artery will be affected. So, you need to be always thinking, and do your blood pressures of both arms. Is there a blood pressure difference? That would be suggestive. Now, other things would be doing a TTE. So you can do a bedside TTE and look for the aortic root, see if there's a flap. And certainly MRI is actually the most sensitive test. You can do 98% strain. And they've also got this left-sided pleural effusion, and that's typically what you will see. So this would be quite indicative of a dissection with the relevant history. Whereas if it's type B, then what you really want to do is stop the propagation of that tear, and this is where medical management occurs. So what you want to do is aim for the blood pressure between 100 and 120. And you can usually do that by treating the pain, but also giving things like beta blockers. But this is, quite serious stuff, and you want cardiothoracic something. A TVAR, whatever written there is, that's an endovascular aortic repair. So that's a new kind of way that like these are being managed and things. But that is aortic dissection in a nutshell. So let's move on to the next question. Okay, let's see. So it seems 47% of people have gone for GTN, and that would be correct. So let's just look at the questions. This patient basically sounds he's having a He's having, you know, an NSTEMI here. He's quite unwell. So how are we going to treat the blood pressure? Well, GTN would be the sensible route. And let's just talk about it, because hypertension is not well kind of done. So if it's chronic hypertension or general hypertension management, you will see the kind of figure on the top right. That is how we know how to do it. Now, start off an ACE inhibitor for younger than 55 if you're black and over 55 CD, and then you add different agents as you go along. The key question here is understanding the risks and the differences between hypertensive urgency and hypertensive emergency. Hypertensive urgency is where you've got high blood pressure. So these patients may have 160 to 180 blood pressure, but there's no signs of end organ damage. Since there's end organ damage, that's an emergency. Now, emergencies here, you know, you would think about is dissection. That's a hypertensive emergency. Subarac, if they're becoming cephalopathic, have they got pulmonary edema? The chest pain is a bit more of an emergency as well. Acute renal failure. And as with everything that we've kind of mentioned today, speed of onset is important. A lot of patients who are coming in with just isolated blood pressure of 200, that's not an emergency. They've got what you've called malignant hypertension, but that's not emergency. They have just poorly controlled hypertension, which they probably had for months. So you don't need to rush around giving them, you know, agents and things like that, providing that their ECG is normal, their everything else is normal. You know, urine dip shows no blood and no protein and things like that, no papillary edema. And the reason why we don't want to rush around with this, particularly in the elderly, is the figure here where it's talking about cerebral blood flow. Now, as we remember about autoregulation and the idea that blood flow is kept and sustained over a variety of mean arterial pressures to ensure the organ functions well. Now, if you've got hypertension, and especially if it's chronic, then this can shift to the right, which means that the body gets used to achieving the same blood flow to that organ, in this case the brain, at much higher mean arterial pressures. And what will happen is, if you actually decrease that blood pressure too quickly, because I give them some nifedipine or whatever not, then what will happen is that actually they will drop off the very bottom of the curve, and now they won't achieve enough cerebral blood flow. And so they can get, in that instance, they would have a watershed stroke. The same things would happen to every organ system. They could get myocardial ischemia, worsening ischemia. They could have worsening renal failure as a result of renal infarct. You see where I'm going? So you want to avoid massive drops. So that's why it's very important to differentiate between these two. Now, in this case, he's come in with this chest pain. So this is a hypertensive emergency. And the key question here is, and the key thing to remember is that blood pressure is deleterious to that heart. Why? The heart is not doing well. There are changes on the ECG. We know that there's some depressions. And remember, when the heart is actually pumping like that, it's going to be occluding its own blood supply. So it's going to become more ischemic because the ventricles aren't work so hard. So we need to drop that blood pressure and really decrease the load, the afterload, and the general work of the heart. So what we would normally do is, you, in an emergency, is aim for parenteral versus oral therapies, okay? Now, in A&E, you will normally see people given things such as like esmolol and things like that. And esmolol is really, really short-acting. I mean, its half-life is a couple of minutes, so it's fantastic, really. It works within 60 seconds and is out of the system by about 10 minutes. And the good thing about it is, it doesn't matter if you've got crap livers or kidneys, because actually it's broken down by red blood cells. Labetalol you see very often, and that's good because it's mixed mechanism. It's also beta and alpha. So these are really good, and that works quickly. So you'll see these used often, all right? Now, what are the aims for what you're trying to do if somebody does come in hypertensive emergency? So he's come in and his systolic's 210. What am I trying to achieve here? I am not trying to get him normotensive. That's really, really important. I want to initially get his blood pressure down by 25%. He's 200, okay? So I want to get him to about 150. You know, he's 210, so about 160 will be fine. And then I would aim for the normal blood pressure over the next kind of 24 to 48 hours. Okay, that would be what I'm aiming for. And as I said, for the investigations, what you really want to do is understand what you're looking for. So as I said, urine dip and ECG, very important. You would want to see especially in a younger person. Say now it wasn't this scenario, but you'll see patients 40 and they've got systolic of 200. You want to be looking at particular causes of that, isn't it? So you might want to do a chest X-ray. Have they got coarctation? You want to examine for that. Do they have polycystic kidneys, which are causing them hypertension? Do they have hypothyroidism? And for all of you wondering why I've put FBC and film, very simple reason. If you have malignant hypertension, you can go into DIC. So I want to look to see the platelet count and to see if there is now any shredding of the red blood cells. So are they anemic and things, because that would point towards. Okay, but in terms of out of those treatments, what I would want to give, the reason with GTN, as we know, is a vasodilator, works very well with the coronary circulation in particular, and it would be not only the kind of one of the quickest agents to give, but actually for the heart, probably one of the best ones as well, because he's probably going to need GTN in the future just to help with its ongoing pain. And as I said, in this instance, you want to give parenteral rather than oral therapies. IV GTN would be really sensible in keeping him on a monitor. All right, so let's go on to the next question. All right, shall we have a... Okay, so it seems we're very well split. So here, the actual correct answer would be, I would be calling the anaesthetist here. Quite simple. The GCS, I'm getting quite concerned here. The blood pressure and everything like that looks okay. This patient might become hemodynamically unstable, yes, but the GCS has actually certainly gone off, and now they're at risk of losing their airway. So this is quite important. Now, would I not want to get the oncology endoscopist? Yeah, I would. But the immediate thing of him, especially before we're going to sedate him and put him into a and have a scope down, is to give him is to make sure that we secure that airway and do what we need to do. We're going to talk a little bit about upper GI bleed. So upper GI bleeds are incredibly common. You will see this quite a lot. In terms of the major kind of causes, the peptic ulcer disease by far is the most common. So this is one that you always need to think about. Obviously, in our case, this chap has chronic liver disease. So I'd implore you, whenever you see a patient, they're probably busy vomiting blood. So examine, look for the signs of chronic liver disease, signs of alcohol overuse. So not only the classical, but are their carotids enlarged? Do they have Dupuytren's? These kind of things. And then remember, in small amounts, you will see varices in about 10%, but you can have these abnormal vascular lesions. Now, in this case, we've got liver disease, and the reason why the liver disease is causing this issue is because of the increased portal venous pressure, which is now raised, and therefore what we get because of this, you form collaterals towards the cirrhotic liver, and these are very friable and easy to bleed. And variceal bleeds are bad; they're prognostic, and 50% mortality, so it's not really a joke. And in all honesty, despite our changes in medical management, the mortality from bleeds hasn't really changed. It's still around 10%. It's incredibly common. Now, obviously, in this patient with a chronic liver disease, I want to be looking for decompensation. Has he now got, because he's got bleeding varices, has he got jaundice, ascites, encephalopathy, and all that? Because they also need management. And you really, when you're doing history with these patients, it's being quick. Yeah. Have you had previous peptic ulcers? Have you had any recent symptoms of them? Any NSAIDs that you've been using recently, or high-dose steroids? Any history of prolonged retching or vomiting? Is it a matter of advice? Now, with these patients, they usually present with hematemesis. They'll tell you it's mandatory that you do the PR. It's not nice, but do it, okay? And remember, these patients can turn up with syncope, and I've had patients who've come in as query collapsed, and actually it's only then that you find that they've been having huge amounts of melena secondary to an GI bleed. Now, in terms of what the aims are in terms of transfusions, you want to transfuse generally if they're less than 7, so that's normal. In the absence of coronary artery disease and severe cardiovascular, then you would move that threshold further up. Platelets, yeah, it's a bit of a misnomer. So platelets, you realistically, to clot, you only need about 20 platelets, your value of 20. But we like to say over 50 because of the procedures they may need to go on to as well. And whenever you have a patient who comes in with GI bleed, you must perform a Glasgow Blatchford scale. That's really important. And a pre-endoscopy Rockall score, okay? Because these are very important. The Glasgow Blatchford score is just there to kind of tell you the risks and the need for intervention. And this will be the ammunition that you'll need when you're phoning the GI endoscopist about the patient. And the pre-endoscopy score for the Rockall just gives you the risks of rebleed and the risks for retherapy, okay? And this is something that's very useful to kind of be aware of. And just do the Rockall score because it can really change the risk of mortality and the risks for needing to go back for theatre and things, but for endoscopy. Now, in terms of management of GI bleeds, what people would say PPIs, you'll see this in A&E. PPIs actually, the major evidence is actually that it should be post-endoscopy, not pre. And Cochrane trials have actually shown that they don't really improve significantly outcomes such as rebleed or need for surgery. But there have been moves as well to see whether or not TXA could work. And TXA, once again, hasn't really shown to do anything for kind of 5-day mortality in severe bleeds. It may still have a role in other ones. But with variceal bleeds, as this patient had, they had vasopressin. And the whole point of the vasopressin is vasopressin's an ADH analog. It's going to cause vasoconstriction, and particularly splanchnic vasoconstriction, so these collaterals and of the kind of gut. And the whole point is that you're diverting the blood away from these bleeding varices, and therefore decrease that. So they're really, really important. And while somatostatins were used, they're not really used anymore. Now, in terms of vitamin K, what we would say is that really giving vitamin K isn't going to do much. Now, if it's severely deranged, INR 1.5, I'm not particularly bothered in cirrhosis. But if it now was kind of 2, you would be wanting to talk and give these patients some FFP as cover, especially before their endoscopy. And antibiotics as well should be given. Why? Because they're high risk of actual infection. I remember if they're having this decompensation, they may have ascites and associated SBP, and certainly 20% of these patients will form an infection. So giving them, usually you'll put them on broad spectrum tazocin or something like that. Now, in terms of endoscopy, what you're doing, you want to give, you will do band ligation, and you'll also do adrenaline injections and clips in the first place. And then realistically, you can use other therapies. So these include balloon tamponade. Now, balloon tamponade is not something done at endoscopy. It's there to buy you time until you can do the score. But it's not rarely done because there's huge risk factors in terms of necrosis of the esophagus, because now you're actually putting pressure there and squeezing the layers of the esophagus. You're decreasing its own blood supply. So there's huge risks, and it's not very well done. But certainly, if this is a patient who's had difficult bleed, then they may need to go into surgery. And it's for these patients, particularly in ulcerative disease, that they will need kind of a mental patch being sewn over. So in terms of how you manage these patients, remember, you're doing your full A to E. You need to have double, 2 cannulas in, or at least one, which is very big. A green is minimum. You want to be making sure they've had an abdominal chest X-ray to ensure they haven't got any perforated viscus, any perforated ulcer. Send off all the blood tests, including clotting and groups and saves. You may want to call the lab and actually preempt that they may have further bleed. So I would usually just keep 2 units in the back, okay, 2 units of packed red cells, just to be available because this patient may become very, very unwell. And these patients can take an awful lot of your time, all right? And you need to kind of stay with them and see what's happening. But as I said, the key things when you're examining them is that you look for any signs of chronic liver disease, you look for signs of shock as you normally would, and that you obviously do that PR, because that will be very important. And we don't talk about lower GI bleeds, but that's an important thing as well, because remember, whilst we expect melena in upper GI bleeds, if it's a high transit upper GI bleed, high speed upper GI bleed, then actually it can present as fresh GI bleed in around 20%. So even in the context of lower GI bleed, most people will ask, gastroenterologists will say, actually, we should do an endoscopy as well to exclude a high transit. So on that note, let's move on to the next question. Okay, so it seems we're quite split here. The right answer actually is using propylthiouracil, and we'll talk a little bit why that might be the case and what are the treatments we use. So this is a classical scenario of, well, actually, if we just go back, this is a thyroid storm. We can see that the patient is running quite quick, 135 beats a minute. The GCS is also dropped, and thyroid storm usually presents with confusion as well as the signs of thyrotoxicosis and temperature. So, here, whilst you need to think of infection as well, and you might want to say treat the sepsis, I mean, it's not, this is thyroid storm, but there might be an infection precipitant. We expect, because the kind of catabolic thing with the thyroid hormone, that there would be high temperature. But you can see that the TSH is very, very, very suppressed, and the T3, especially the free T3, is incredibly high. So what is thyroid storm? Well, firstly, it's very, very life-threatening, and patients will come in as in a hypermetabolic state. Remember, thyroid hormone works on the sympathetic nervous system, and many of these patients have a primary cause of hypothyroidism. So this could be a Graves patient. This might be your toxic your toxic goiter, or your autonomous nodule. And when you're kind of looking at these patients, you need to first of all see the degree of the hypothyroidism and see that end organ damage that we've said, and see if there's end organ cognition changes and problems with actual organ dysfunction. And as we would expect, one of the key things here is looking for things like AF, which is obviously very common. And you wouldn't treat, whilst you would use beta blockers as part of a normal kind of thyroid storm use, and for AF, you would want to treat the underlying thyroid storm and see if that resolves. Now, you can use scoring systems in thyroid storm, and this is the Birch-Rortowski score, and that just looks into whether there's a precipitating agent and whether there's any end organ dysfunction. And basically, if your score is over 45, then you can be relatively sure that it is. And because of this kind of increased thyroid hormone, you get an acute stress response. So just like if you were running away from a tiger, I would expect your white cells to be up. You will get hyperglycemia because you're mobilizing your sugars to, your fight or flight, and you will get hypercalcemia just because of increased turnover of bone. Now, in terms of risk factors for thyroid storm, one of the most common is probably infection, and another one really is surgery. So patients, when they're having Graves, and you're giving patients, we've talked about this in our previous talk, if they've got Graves' disease, for instance, and you're doing surgery on them, you would stop a lot of their thyroid medications before, because once you're touching the thyroid and affecting its vascularity and things, you can increase hormone release and you can get thyroid storm. So we need to be quite careful. Trauma as well is a big cause as well, and that can be local to the thyroid or systemic as a part of the stress response, and as well as acute iodine, taking acute exogenous iodine. So by that I mean, if you've got a diseased goiter, this goes back to what we've described previously. But if you've got a diseased goiter and you take exogenous iodine, then you paradoxically get increased thyroid hormone synthesis. It doesn't normally happen. Now, in terms of treating this, because the major risk here is the heart is going to keep pumping really, really quick, it's not refilling properly, is that they will form hypertension and heart failure. So this patient may very much get heart failure now. But what you really want to do is block the release, if you can, of thyroid hormone. You want to stop it being converted from T4 to T3. That's because T3 is about 10 times more active biologically than T4, even though it's in much less concentrations. And you want to treat the overriding symptoms. So you want to, give the beta blockers, as we said. And unfortunately as well, thyroid hormones are part of the enterohepatic circulation, so they can go around quite a lot. So we can do the kind of 5 Bs. And it's because of this then, so, that we give those kind of treatments. Now, in terms of blocking the synthesis, we obviously had different ideas there, carbimazole, propylthiouracil and things. The reason why propylthiouracil is favoured is because it has dual function, so it blocks not only the release of thyroid hormone, but it also blocks the actual conversion from T4 to T3. So it's supposed to be as a kind of double entendre, double effect, which is good. Likewise, your propranolol will also do the same. And when you use beta blockers in this instance, you won't use your bisoprolol because you want really a mixed non-cardiac specific. And you can give that IV, and the benefits are short acting, it works quickly, and it can really help immediately in trying to avoid some of the problems that we've discussed. And steroids are used for the same reasons, to dampen down the inflammation, perhaps even of that thyroid gland, and to prevent that conversion. So realistic, and you would give that as hydrocortisone, so a normal kind of standard dose would be hydrocortisone 100 milligrams IV. So in thyroid storm, the key things are just trying to block the synthesis and block the ongoing release. So, and that's the point. So you can do that by, as I said, just giving them propranolol, giving them some propylthiouracil steroids, and really, what you want to do is avoid, if possible, trying to take out the thyroid, because you are just going to make the situation. So that's thyroid storm. So let's go on to the next question. The last
Hi, Dom.
Hey.
All right, are we finishing up? I think people might have to head off.
Last question.
I think it's showing, the answer is showing up as well.
Oh, damn it. Oh, my bad. Oh, right. I'm sorry. Okay. So 100% got that right. That's good. Sorry about that. So we'll just go through this quickly. So let's just say why it isn't the other ones. Paracetamol won't really cause these symptoms that we're describing here with the respiratory rate and the irritating ringing and things. And we would expect it to cause metabolic acidosis, particularly in the setting of overdose. Ethylene glycols, that will cause a metabolic acidosis once again. I remember this is something that you find in antifreeze, and that causes the major toxicity is actually kidney failure because you form oxidative thorns. Diazepam can cause metabolic actual acidosis because it actually increases lactate production. So, so that's a cause, but that would not cause the alkalosis that we can see here with a pH of 7.5. And then codeine, well, that's not going to do anything. So this is aspirin. So let's just talk about aspirin overdose. So realistically, there are kind of 3 phases of aspirin. So originally you get hyperventilation, and this is because you've taken the acid, your thyroid bodies work this out, and they measure this and realize that actually this isn't quite right, I've got a lot of acid, so you try to stimulate your respiratory centers. You get direct respiratory centers. So you try to hypervent. You then eventually come to the point where you've got respiratory alkalosis and you try to pee out the acid as much as possible, but this actually starts to not work, and then you get progressive metabolic acidosis. Now, the reason why aspirin forms an acidosis is not just because it's acidic, okay? It's actually because it's blocking the Krebs cycle, and therefore you get anaerobic metabolism. So that's actually quite important. And in terms of, investigations, it's mandatory whenever you see a patient who's come in, for instance, a paracetamol overdose, that you always test them for salicylate as well, just because they're quite common. Now, in terms of kind of overdose and what's mild and severe, for mild, you need to be about 150 milligrams per kilo. Severe is over 300. And, what you might find in mild is that they'll get these symptoms of nausea, vomiting, and tinnitus. Whereas if they're severe, they can get deafness and seizures, and they'll have and, you really need to work it out clinically how severe it is, okay? And you should wait 2 hours before trying to measure the actual salicylate level, because you want to ensure that all of it's absorbed and that you get the true value. There's no point doing it too early, and then it won't be risen enough. Remember, if it's in the first hour, then you can give them some activated charcoal, which is often very important. Now, in terms of treatment for this, then we can use, and the mainstay is actually giving urinary alkalization. And the whole point is that salicylates, so as you get the acidosis, the progressive acidosis, because you're blocking the Krebs cycle, salicylate will move into the extravascular space, okay? And it can move into the CNS. And so what you do is, if you alkalize the urine, so you give them bicarbonate and things, then actually you turn the salicylate into its ionized state. And when it's filtered through the kidneys, it basically can't be reabsorbed through the tubular epithelium. So basically you give them bicarb, it's not there, and alkalize the urine, not to neutralize the actual acidemia that will be present towards late stages, but to actually ensure that the salicylate can't be reabsorbed in the kidneys. You want the pH between 7.5 and 8.5. So you'll just ask, you'd ask the nurse just to do it. You would do that every couple of hours, just give them the correct treatment. So you would want to do that particularly in the case of, as I said, severe acidosis, and if they're now, and if in the context of severe overdose, if they've taken over 300 milligrams per kilo. Now, hemodialysis is actually something that you can use, all right? And you would do that if they've got quite massive amounts of salicylate in the system. So they need to take huge amounts. And, you would consider this as well if they were having symptoms, for instance, of coma, convulsions, and if they go into pulmonary edema. These are the instances in the context of salicylate poisoning where you would really consider actually doing that. And just to clarify, when you're giving the bicarbonate in this instance, you would give sodium bicarbonate, not normal percentage, but 8.4 to the very high percent. And you would just keep giving that. You give it quite slowly and just measure the pH as you go along of the urine. And with these patients, then you'll find that within a couple of hours, actually, they'll start to, they may very well alert and their end organs improve. All right, so that is that. Here are some resources. And now I believe it is questions. Am I right to go through questions, Ian? No?
Yeah, man, go ahead.
Yeah, so somebody asked about, can you explain about albumin and the metabolic acidosis again? So the whole point is that albumin is, so basically albumin, as you know, controls a lot of your electrolytes. We correct it for things like calcium, and it binds to most drugs. Well, it's the same with regards to this. If you're in the setting of low albumin, then what will happen is that you won't accurately estimate the tissue anions, because what happens is basically they're involved with binding of those. So you will actually say now they have a low albumin. The albumin is, we'll say 20. They may come out as a normal anion gap, because if there was the normal albumin in there, then actually those anions wouldn't be in the cell, they would now actually be in the plasma, which we could measure. So that's the reason why. So you just need to kind of correct for that. Although, if it's an acute illness and they come in for, say, now sepsis, you wouldn't expect their albumin to have taken such a massive hit in the first instance. So, that's the thing. So, but what I'm saying is, if you've got somebody saying a poor nutritional status, chronically unwell, now come in like that, that would be when you would want to consider that. Okay, and there are further tests you can do as well to confirm that this is a true metabolic acidosis, but that's like ITU delta ratios and stuff. You don't need to know about that, but it's just a little thing to be aware of. Somebody asked about, can you explain VBG versus ABG, when to use what when? So realistically, the difference between VBG and ABG is negligible. It's just obviously the only real reason to do an ABG is in the setting of deteriorating oxygen saturations and concerns regarding ventilation. Certainly, VBGs are much easier. So if you're doing it, for instance, in our DKA case, then you would like to do that for VBGs. That's more than sufficient. And obviously, think about it as well with a VBG. Even if you've got a VBG, say now with somebody who's ventilating poorly, sorry, I should say oxygenating poorly, but the PCO2 on that VBG is normal, then they're not hypercapnic. Therefore they can't be hypercapnic on the ABG, because obviously you would expect the venous carbon dioxide to be higher. So that can be reassuring that they're not in type 2 respiratory failure. So that's something just to do. But generally, unless it's a severe ventilatory problem, I don't do ABGs. I do VBGs for the mainstay for pretty much everything.